Hello, everybody. So this is now April 30th in the morning, a little before our class, and I'm going to give you the dictation slash presentation for the lecture. Even though class is canceled today because of the power outage, hopefully you'll get a chance to take a look at this today or tomorrow, and certainly in the very near future. This is the PowerPoint. I loaded it. This is the Chapter 23 Nestor PowerPoint on wounds. That appears at the bottom of your week 4 blackboard, and this is where we begin. And you can see it starts with maybe the one that's the most important to discuss, and we're going to get to it, which is tetanus. And you can see this is back to the first week of our class with Koch and his laboratory and being able to determine and understanding it's a toxin. And the same thing is true of diphtheria, which we talked about. And you'll need to know both of these when we get to the final exam. This is just an example of a really bad wound. I can't tell exactly where it is. It's split wide open. And there's so many different factors. I have a ton of information on that wound outline. I've been dealing with wounds, or rather, not since I've been teaching for the last 25 years, but for the prior 25 years, I've been dealing with a lot of wounds and wound healing. I have a lot of experience in it. I worked in wound healing clinics before the modern day wound healing clinics. All of those things that are there. And yes, all of these factors are important. The organisms that are there, the immune system, maybe the underlying thing more than anything else. Because if there's a wound, by keeping it clean and taking steps if you don't want to let infection get in there, is a critical point. But the critical piece about this, okay, is the wound. The simple wound that you and I get most commonly is a typical kitchen injury. You're working with a kitchen knife, you're working with something sharp. It's a clean, sharp cut. If it's really deep, maybe it needs stitches, or if it's really long. But by and large, these are relatively innocuous. They may be painful, they may be unpleasant, they may even require stitches, but typically they're what we call a non-tetanus prone wound. So it's all about the minute we start to slash, tear, have irregular edges, embed dirt and debris inside of a wound. So those are what we call tetanus-prone wounds, and there's a total different approach to each one of those. I mean, it's the whole idea when we see one of these and you go into the emergency room. We talked about it before, early on in the class, and they see a cut. They're going to want to give you a tetanus shot because that's the concern. Okay, unless they have proof positive of when that tetanus shot was, they're going to recommend a tetanus shot. I told you the anecdote. It was 3 years ago with my foot. Dropped something on it, took about 3 or 4 stitches on the top of my foot because the dog dropped something and it ended up on top of my foot. But who the heck cares? And I knew my tetanus shot was 2 years earlier. I knew exactly when it was. And I promptly refused the ER doc because I knew exactly what it was. And I went into my family doctor's office and I confirmed that just to make sure. I told him I would confirm it, and if it was not, and if I was in error, I would have it get a tetanus shot. But I knew exactly when it was. I knew it was like in April of 2019, just off the top of my head. Now we're 6 years later, a little bit different now. Okay, if I get another one of those, probably get a tetanus shot. Just to give you the idea. So that's really the underlying issue. It's the whole tetanus shot thing for all the clean cuts that we see in the emergency room is for the next time. In case you get a really bad one and you're stuck someplace, you're camping, you're out in the woods, there's a traffic accident, all that type of stuff. So be wary about that. Talk more about tetanus, what it is, and all of these types of things. So we're talking about punctures, tearing like laceration, contusion, damages underneath. That's another subset of problems. But it's a wound, but there doesn't necessarily mean there's an overlying wound. Abrasion is a typical scrape, scraping your knee. And then we have gunshot wounds and burns. And that's sort of the thing that we forget about. Burns or wounds. There's thermal damage to the skin, and a burn, by definition, as you will learn shortly, burns have nothing necessarily to do with heat. Burns are thermal injuries. It's a much better description because you can do as much damage to the skin as you can with heat and with cold. the only case of tetanus and I did not see it in full-blown tetanus, but I saw the patient before it became full-blown tetanus, was in a case of frostbite. A homeless individual, and maybe I told you about it before, had got frostbite on his hands. This was probably, it's one of those, like kind of the weather we have some of these mornings where it's wet and cold and near freezing. And he had those typical, kind of gloves on where your fingers protrude. You see this a lot, where the homeless individuals and the street people are just trying to do anything to keep warm. And it's very sad. And he ended up with gangrenous fingers from frostbite. Okay. And the error that was made, and I was 2 months away from leaving, and I was off that rotation. And to be very honest with you, I wouldn't have thought of it either until I heard about it 3 months or 4 months later when I was doing a presentation and had come back. I wasn't doing the presentation, but I had come back to that residency program for a seminar they were having. I was listening to and talking to some of my colleagues who were there, that he had succumbed to tetanus because he developed all the classic signs that were associated with tetanus. That's from a burn. In this case, it's a thermal injury burn, not a heat burn, but a cold burn. Be aware, anything that causes necrotic tissue, whether it's one of those irregular lacerations where the skin is making you start to get those black edges, that's a tetanus-prone wound. The minute you see even a clean wound, we even see it in post-op. When post-ops start to get infected, that's when you go back here and go, maybe I ought to just double check on this tetanus prophylaxis thing. Because if you don't get it there now, you could be in some trouble. All of those are kinds of things that run through your mind. And I realize the physician's mind is different from other healthcare practitioners' minds. But it's always good to be aware of those things, because it's even in any position that you're in, you can kind of turn around and say, gee, I wonder if he needs a tetanus shot. You don't have to say, someone can say, well, I don't think so. That's fine. But at least you put it out there. Think of it that way. You learn to do, once you get on the clinical floor, you're going to learn that there are experienced people, there are ways to talk to people. Ways of being, you want to express your opinion, but you've got to find ways to express it. That's something that only experience will teach you. So all of these things, I'm not too worried about collagen and fibronectin and fibrinogen and blah, 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 like that. These are all, these tissues, when they talk about protected tissue, the skin or linings protect it. And because of that, they're a perfect feeding ground for microorganisms, the best way to describe it. And if the wound starts right away, we call it granulation tissue. It's beautiful, it's red, it's pink, it's healthy. They start to fill it up. And then as time goes on and it matures, it shrinks and it will become scar tissue. Okay. And the whole idea of what we want to continue to do, and this is a fine line, this is a mistake people make. A lot of times they say, well, you got to keep that wound clean, and people are debriding it, or they're using these stupid wet to dry dressings. Don't tell the nursing people about this. And they peel off granulation tissue is there. There's a whole science to wound healing, and I'm hopefully it's being imparted as you get into those courses for many of you going into nursing and healthcare. But you want to remove dead, damaged, and infected tissue. You do not want to move granulation tissue. And the whole idea of keeping wounds dry is very passé. Moist is better than dry. Dry begins to destroy these new cells that are being built up and destroying this healthy, what we call granular bed. That's going to be the blood supply for the skin and for the underlying tissue of the skin. Some neat pictures there. An abscess is pus. Again, pus is normal when there's an infection. A lot of pus-producing organisms, and principally they're all bacteria that do this. And it's, again, we don't want to cultivate or culture the pus. That's another mistake. When you get to, I'll back up here, the whole area of the wound, if this is filled with pus, you've got to get that out of there. So whether you delicately remove it, you aspirate, you take like a little sterile pipette, or you just take a gauze pad, wounds are there, the infection is there, at the deep in the base and in the sides. That's what you want to culture in the absence of the pus. Because pus has dead bacteria, white blood cells, tissue debris, and maybe some surface bacteria. You want to find the culprit, not normal microbes that are in there. But the whole idea is you got to let the pus have a way out. That's there. It's part of your body's defenses. Okay. And it's really effectively localizing, means walling off the infection. Most of the time it comes to a head, like a tiny pustule, and warm, moist compresses will do that. Maybe some topical agents will accelerate it because they'll pull moisture with them. In the old days, they called them drawing salves. That's actually how they worked. Okay. A lot of people will poo-poo that. They'll say, "Oh, that's not work." Well, yeah, there's nothing magical about them, but they're hyperosmotic and they pull moisture toward them. Okay, so a lot of times you have all of these are difficulties. So what we often have to do is we have to do what's called I&D, incision and drainage. If it's one of those like a boil, or if something is deep inside, sometimes you just got to open it. The concern is if it's still in there, you got to open it up and allow it to drain. And a lot of times, what we'll do is we'll flush them out with antibiotics, with liquid antibiotic flushes deeply. We'll pack them with sterile gauze or sterile gauze that's impregnated with some type of healing agent, and gradually advance it. That's because what you don't. I'm going to go back here. You imagine this is not there. You want wounds to heal from the bottom up. If they close over prematurely without healing underneath, you can see this is healed underneath. Look, it's healing from the bottom up. But if it closes over and you still have a hollow in there, again, that's a breeding ground for infection. It's there. And there's, you can see the one with a pus, the example for that. Tetanus. Anaerobes are a big problem. Anaerobes are not a problem in living tissue because we're an aerobic organism. Anaerobes are a problem, and particularly like an endospore form or like tetanus. That's why it's such a big culprit. It's everywhere. It's constantly in our environment. It's on the bottom of your shoes. It's in the carpet. It's just there, and the endospores are effectively indestructible. Okay. The trouble is, so any type of debris that gets in there, the likelihood it has endospores in it of the Clostridium tetani. And as you can see, it's not the only. And then when you have damaged tissue or these what they call polymicrobial infections, you have lots of ground. The tissue that's being destroyed becomes anaerobic. If it loses its blood supply, it becomes anaerobic. If it becomes necrotic, turns black, like that case of frostbite. Or when you see something we were going to talk about called dry gangrene, that's all parts of it. And that's effectively what happened in that frostbite patient. All of those, unfortunately, are breeding grounds for this. And so you have to be very aware. And they're difficult to treat. There's a limited subset of antibiotics. Most of the time, metronidazole, Flagyl, clindamycin, although it has gastrointestinal, pretty severe, are pretty much drugs of choice for that. Okay. So, and all of these things, abscesses, toxins, infections. When infection gets into the area where an artificial hip or an artificial knee and the surrounding bone, now the bone is infected. It's called osteomyelitis. Whatever coatings that are, and generally these things develop biofilm are filled with infection. You have to remove it. And at that point, you're in trouble. I mean, now you're dealing with a wound that has to heal and heal sufficiently. Okay, because the only way you can get rid of infected bone is to cut the bone out, is thoroughly to get rid of it. I mean, you may be able to quell it with antibiotics, but effectively in that type of thing, it's a minefield. And then you're left basically with a non-functional joint that probably all you can do down the road is fuse. Wait till everything heals, get rid of the infection, put more bone in there, probably from the bone bank, which is usable bone donations, and effectively fuse the area. It won't function anymore. It's horrible. And so there's all of these things. It's a freaking minefield. The best way I can describe it for you. So there's really serious problems that are associated with this. I can't emphasize it enough. And so, and to me, and I wrote this in the, this is probably the pecking order. Okay, Staph aureus to me, number one in the hit parade, and then of course the subset of MRSA, community or hospital acquired. Streptococcus pyogenes, that's good old Lansfield group A, the strep throat strep. I mean, look at some of the wounds. Okay, delayed healing, abscesses, artificial devices, and toxic shock syndrome. We see toxic shock syndrome nowadays more than anything else from wounds. For years, toxic shock, and I think they talk about it in this, but toxic shock was something that came from a tampon. And when we first identified it, it didn't come from that. Toxic shock is a specific stain, mostly of staphylococcus, but can be streptococcus. That's what we call a super antigen. You might remember we talked about that. That ramps up like 20% of your helper T cells in a cytokine storm. And they developed this, it was a convenience tampon that was so it only had to be removed a limited number of times a day and changed. The trouble was it became a breeding ground and particularly favored this strain of Staphylococcus and Streptococcus, which happened to be abundant in a fair percentage of female reproductive areas. So, long story short, this, and then on top of it, because of its indwelling nature, it became somewhat almost like an irritant to the area. So it broke down a little bit of the barriers, and this toxin was able to get into the bloodstream because these bacteria, once they started to multiply, this toxin, and a number of people died. This was almost exactly in 1980. I can remember it then. Women stopped using tampons for, the tampon market crashed, so to speak, for the better part of 2 years until they identified what the source was. They thought it was all tampons, and then finally identified what it was and what the problem is. And then people resumed going back from the sanitary pads of days gone by into the tampon years. Very interesting. Not that terribly long ago. But now we see it's interesting certain wounds, and that typically certain kinds of wounds are like that, uh, where they can cause that. Streptococcus pyogenes is very famous for neck fash, necrotizing fasciitis, the flesh-eating bacteria. It's a microaerophilic bacteria, very specific conditions. It's almost like it requires some oxygen, but a lot of oxygen will kill it. And again, it secretes one of these notorious, super antigen toxins, and necrotizing, it sort of liquefies. And the unique thing about this is the skin stays intact, the bone stays intact, but everything in between is just getting gobbled up and liquefying. There's a ton of gas. This is another one where the tell that you can get from just taking an X-ray of it without having to do contrast or imaging or MRIs or CTs, just a plain film. You see subcutaneous emphysema. You see gas accumulation, gas bubbles under the skin, and once you see that, you immediately, probably you're lucky if it's in an extremity, if you're getting away with just an amputation. I mean, you might have to do a hip disarticulation. In other words, take everything off from the hip down. If it's in the lower extremity, everything off from the shoulder down, because it spreads literally like wildfire. And if you don't do that, it's potentially lethal. So it's just such a horrible. I've seen certainly one and likely two cases. One happened in a relative of my first wife, long deceased, was diabetic. Remember, they have limited oxygen supply. I saw him, saw the start of it, thought it was phlebitis because it was red and inflamed. Didn't want to take any chances because he was diabetic. Very brittle, very poor circulation. Lovely man. And he's probably, I would dare say when I saw this must have been, over 70 plus years old. And it just didn't improve. So I gave him a prescription for Keflex or something like that, whatever it was in the day. I was looking at him, and it didn't improve. And I saw him a few days later. I'm like, I don't like this. And I called up and I made sure he got a referral to the man who was the chief of surgery at Montefiore, down at UPMC's, and that complex next to Presbyterian's Montefiore Hospital. And he called me back in my office and said, Lou, he said, I'll tell you exactly what it is. And he said, I would not have known it unless I saw it in my residency when I was a resident in Boston back in the 40s. He was older then. This man, I'm sure he's no longer with us. And he said, that's necrotizing fasciitis. And he says, the only reason is I saw it once. And so, and if that's what doctors have, when you see it once, it sticks in your mind, particularly if it's something that you didn't identify right away or you missed. And pardon me, unfortunately, he did lose his leg because of this, but thankfully, he was able to survive quite a bit longer despite losing his leg. So it's very, any other one was in a drug addict. I'm pretty sure that was the case. If not, it was a horrible under the surface infection from, again, IV drug users. That's where we begin to see this toxic shock. And this is when I was a resident back in Philadelphia. So interesting things. And lastly, Pseudomonas. It's in the soil everywhere. It typically is. The problem is, again, immunosuppressed people, people in the hospital, wounds with a lot of damaged tissue, and as you're going to see, Pseudomonas loves burnt skin. That burnt tissue that you get from a bad burn, second degree burn, certainly third degree burns, it's awful. It's got that green color you might remember from the lab. If you had a Pseudomonas and you had some on the plate, maybe that was an unknown, and it's just awful. It smells bad. It's a sickening kind of like a fecal smell would be the best way to describe it. It's just gross. And burn patients, there'll be some illustrations of this. It's almost like you could peel off this green colored debris. There's a pigment that fluoresces green in ultraviolet light, but sometimes it turns everything green. And I've seen that. So here we are, pus producer, big surgical incision, staphylococcal infection over there, nasty. Could be could be, but toxic shock would be unusual to see that from this point in time. It could happen, certainly. You have to open it up. Normally, this is a tip. This is the kind of thing that you're struggling for antibiotics. Part of my voice, as you can see, you're going to find in the hospital you get both MRSA and MRSI. So, and that's normal flora, Staphylococcus epidermis. It too, over time, has developed methicillin resistant. It typically doesn't infect healthy people. It rarely infects healthy people. When in the hospital, you don't have healthy people. And if you've had surgery, immediately you're a compromised host. That's a lot of why we do things now in surgical centers and outpatient units where they do the outpatient surgery is separate by some degree from the inpatient units, just for that reason. I mean, there's a certain amount of knowledge for parts of it. So here you can go, all the thing. Staph epidermis, most common cause of healthcare associated infections. Well, aureus is more serious in the sense of destruction because of the coagulase and the other byproducts that it produces are a part of it. The epidermis is a little more common from a standpoint, numerically speaking. And if it's MRSI, and that's the way I classified them in my charts way back when, MRSA or MRSE, and then MSSA and MSSE, methicillin sensitive or methicillin resistant. It was methicillin sensitive, easier to treat. And again, the coag test is the winner. And all these different factors and the super antigens and the cytokine storm, they're all there for your viewing pleasure. Again, it's not as severe. We do worry about it a lot in artificial joints. We worry about it in certain kinds of catheters. It does adhere well and it bonds well to biofilms and things like that. Okay. And so, and the fibronectin plays the role. It in a compromised host, now it has the potential to be extraordinarily problem. And look at the other things. What happens is it loosens and gets into the bloodstream, abscesses elsewhere, bacterial endocarditis, particularly in immunocompromised, that's life-threatening. So just the fact that it's not as severe an infection in the way it starts or appears initially, it doesn't make it any less problematic. All the risk factors that are there, and again, And you can see like that. And then these different emergent ones we had talked about previously. And it's, again, it's all about how you, it's a simple statement. It's more than cleaning, it's treatment. Do you debride it properly? Have you treated it properly? Have you, yeah, I mean, there's ways to get rid of debris that's in there without having to cut into tissue. We can do enzymatic debridement. There's all sorts of techniques. There's a whole schedule, and that's what modern day wound healing is about, to be able to develop these things. Should have brought a drink because my voice is killing me. Hold on. Do you have something here? I'm in bed with the dog. I know, weird though. Maybe he's here at my feet, occupying it in one of our bedrooms. Here's strep pyogenes. Strep pyogenes wounds are easy to treat, and penicillins, and maybe we're developing something that's not. This is not easy to treat. This is spreads lightning fast. The fastest thing you've ever seen, can kill in a day easily. Staph can kill in a day. This will kill in a day. Staph can. Staphylococcus can. Neck fash will. And there's also, I mean, childbirth fever to some extent was a variation of this. Puerperal sepsis. There's fascia are planes. Fascial planes are divides in the material. We dissect in the laboratory. You get an idea that you almost can spread tissues apart. Those are called fascial planes, like between muscles and overlying fatty tissue, and in between the muscles, how you can somewhat separate them. Those are fascial planes, and those infections spread. They take the path of least resistance. They don't spread through the muscle; they spread alongside of the muscle. Would be the way to express it. It's not the only bacteria that causes it. By far and away, it would be the first one you'd have to suspect. This is what it looks like. Fulminant. That means spreads like wildfire. Suddenly, hours. Are there subacutes? Sure. Very painful. Stretches the skin but doesn't split it. Discolors the skin. Okay, without treatment, shock and death shortly. That's why this has to be amputated. It's not even a question. You can't just open it up, but there's nothing left. If you open it up, everything spills out as a liquid. It's a mess, and you're down to bone. There's nothing left to cover it. It's just lost. And here we are, good old strep pyogenes, Lancefield Group A, different types of things. This is all these awful spreading factors that are there, and that's one of the things that makes it so dangerous. That's there. And so these are, again, certain superantigens. This can cause toxic shock, just like Staphylococcus. This is that protein destroyer, superantigen B. Okay. And again, the part of it, what the shock aspect comes from, is that massive release of cytokines. Those basically cause wide blood vessel dilation, like life-threatening drops in blood pressure, etc. The pathogenesis, how it works, is right here. You don't see it. It's much less common than people think. It makes headlines. That's why people are aware of it. I read a study, this was maybe 10, 15 years ago. I think that there were 125 documented cases in the United States in 1 year. So this is not something that's that common. But yes, these are all the different risk factors. So I saw it in a diabetic patient and a drug abuser. But all of these things, they can cause, they're unusual kinds of wounds. It's almost like embedded, but still has the ability to receive air. So, I mean, these are just additional risk factors. Just extraordinarily immediate is the right word, sir. They have to go. They're going to the operating room now as soon as it's discovered. Okay. And here's the Pseudomonas nugget. This is about wounds. Again, this is particularly about burns. Major problem in hospitals, because major problem in diabetics. One of the first things, if you have a sort of a foul-smelling wound, particularly, you start thinking about Pseudomonas. We did all the time. Thermal burns, absolutely. Burnt tissue, I mean, I don't know about so much about frostbite tissue, but burns, absolutely. Different things. It can be, it's all around us. It's part of us. And so maybe, contamination in the water in a pool or from a rash, contact lenses, all of these types of things. Again, drug abusers, piercings, which you should be very well aware of because they're so much more common today. Does that apply to tattoos? Also, don't know. Cystic fibrosis, that's an unusual subset. Here's the green. Okay, here's a stain, and all it basically has, what's interesting, it has a flagellum. I don't know if it shows up. It's gram negative, not gram positive. So, I mean, this is probably just a simple stain. This is the typical culture plate. Turns green. Maybe that happened to one of yours, and you get this kind of yuck that occurs there, and that's all stuff that's got to be removed in order for that to heal. I mean, horror stories with burns. There was a fire at the old St. Joe's Hospital in Philadelphia, which was about a good 10 blocks from where we were. We was the next closest hospital to ours. And eventually they acquired the hospital I was a resident at, and we got overflow from their burn patients. And, it's a nightmare. We had patients on the sun porches, tripling up in the rooms, a lot of them with infection. We didn't know where to put them. And watching them peeling off the debris, so painful. You had to pre-medicate people just to be able to do it. Green pus, gram-negative rod. It has the single polar flagellum. That's the idea. Everywhere. And you can go through all of these types of things. Again, a variety of toxins that are involved. And the fact that pigmentation is really an identifier you should remember as well. You might remember from a previous question or another exam, the fact that it required, typically we're treating with gentamicin, which is an aminoglycoside. Interesting stuff to read through rather. And that was the problem. That's why hospitals now, I don't know if they restrict it, but they frown on, bringing so-and-so flowers in a hospital. No, thank you. Highly resistant to antibiotics, very difficult to treat. Best you can do. Here's the tetanus nugget. So that's the spasm. I understand that the spasm is so intense, and typically when an infant would have this, it's almost always from necrosis of the umbilical stump. So that's typically what happens when you're so careful when a baby is born, because you want, effectively, what you want is the umbilical stump, where the umbilical cord protrudes, and when it's cut, you want that to necrose. In other words, you want it to dry out. You basically want it to dry up and fall off naturally. So you very delicately cleanse it, maybe with a little bit of peroxide. You watch very carefully to make sure it doesn't get infected, because that would be a tetanus prone wound, a la the frostbite example that I was telling you about. That's my speculation from that. Don't know. So what happens, and this is the first part that happens, you're gradually paralyzing muscles that are there, and muscles you use a lot. So difficulty swallowing, and that's why they talked about lockjaw, because muscles that you use swallowing and speaking so much, we use frequently. And they're the ones where where the problem sort of manifests itself. Uncontrollable spasms, and people breaking bones, severe fracture. It's just a nightmare. Terrible thing. So all of that, regurgitation, and spasms there, and pneumonia. This is all part of it, and it's fatal. Let's say all of those types of things are absolutely true. That's why. Now, fortunately, you would hope. I don't know why the mom's antibodies. Maybe this is possible that this birth mom was not tetanus current and unable to, and theoretically her antibodies should have covered it. I mean, I have no idea about this case. I'm just openly speculating as I look at it. So that's the nightmare. And once the tetanus starts, once that toxin is being produced, even if you get the antitoxin into them, the likelihood they're going to survive is pretty limited. And I'll get to that in a second. So it's an anaerobic, gram positive, and you can see what's interesting. If you remember in B sub in the lab, the endospore is typically in the middle. These Clostridia, they're always sort of offset. They're close to the end. They look like a little tennis racket type of thing. And this is what happens. It's another one of those AB toxins. And effectively, what it does is effectively the signals going to the muscle are always going to be stimulatory. Every time a muscle gets a signal, it's always going to stimulate. It's never going to have the opportunity to relax. It's sort of what happens because of this. So it prevents the release of the inhibitory neurotransmitter, so the muscles contract without control. There's nothing going to slow it down, it's only going to speed it up. Everywhere, just everywhere. All the typical things you heard about. Less available and when you say so it's all about the availability of health care and the availability of the immunization. Here's the neonatal tetanus that's proper wound care. Individuals who get tetanus either not immunized or miss scheduled booster shots. So effectively, what happened to that homeless individual? Unfortunately, obviously he was. I'm trying to get it right with his words. He didn't have. Nor would you expect them. And I mean, retrospectively, I guess that's something that always sticks in the back of my mind. Why nobody, including we were residents, but nurses, residents, physicians, it's just usually nurses were thinking of this stuff first. Okay, so what happens? Now, years ago, it was difficult to give immune globulins, give them a dose of the antibodies. If they are not tetanus current and it's a tetanus prone wound, you must do that. In the old days, they used something called horse serum, and people would have horrible allergic responses because they would be effectively utilize, develop it from a horse. They would get the antibodies from horse plasma. Exactly. Maybe the horses didn't respond the same way. I do not know. But we called it horse serum. So what's interesting is now we make the immune globulin ourselves. We don't have to worry about it. So we make the immune globulin in the lab, so we do not have that allergy type of thing. And I'll go through what the schedules are. And so effectively what the globulins do, it's an antibody. It detoxifies. It neutralizes the toxin. It's passive immunity. So it only lasts for X amount of time, but it's really important. And obviously muscle relaxants, antibiotics at the same time. And all of these you would have to do if you suspected a tetanus problem. You'd have to give somebody a tetanus shot for prophylaxis going forward because you might anticipate that they're going to, but basically the way you hit it in all directions. You use the immune globulin, you use the tetanus prophylaxis because remember there's diphtheria and pertussis in that as well. So they would be equally prone to any of the other two. So you just have to give them a tetanus shot to make them tetanus current, even though their immune system would be responding to the tetanus. And you should use antibiotics to try to kill the infection anyway, even though it doesn't impact the toxin. So all of those are part of it. And there's different schedules, and I don't necessarily agree with everything there. So DTaP stands for diphtheria, tetanus, and acellular pertussis. That's the kind of toxin pertussis. It's always been the hard one that's there. If it's a schedule, it will be every 10 years. That's the thing. And it's all a question, do we have documentation or is the patient recall specifically and we can prove it? So if it's a clean minor wound, I mean, if they haven't, if someone who hasn't had 3 injections over time, in other words, a child, let's say, in a clean minor wound, yeah, that you're going to give the dose of the toxoid. Everybody else, you don't need it because they're fine. If it's clean and minor, you theoretically don't. But the reality is, I mean, a bigger part, you should do it here. That 5 to 10, mine would have been in that category. But even though I knew when it was, they were still trying to give me that one. But the reality is, I bet you in the 5 to 10, if it was me, my patient, 5 to 10, I'd go for this tetanus shot. Immune globulin, it's clean and minor. You don't have to worry about it. All other wounds, 90, 95, 98% of wounds are clean, minor wounds. If they're unknown, you're always going to give the toxoid and you're always going to give the immune globulin. If they've been fully vaccinated, you probably do not have to worry if you have documentation that they're fully vaccinated. If you do not only do you have to give this, I feel that you have to give that. So I disagree with the chart in that regard. I don't know if this chart is current this time. I don't know what the thinking is of all those things, but I would err on the side of caution, particularly since the tetanus immune globulin is something that's very unlikely to have an immunological response, not like the old days of force serum. That's my 2 cents. All the above. That's here. 8-day incubation period. So once that infection, and remember, the tetanus shot's going to take 2 to 3 weeks to ramp up enough antibodies to save somebody's life. I mean, you're playing with fire if you don't use the immune globulin. That's what I think. We were a little more aggressive back in the day with the hospital because we had homeless individuals and street individuals and people who didn't come to the doctor that often. This is gas gangrene. This is an infection. Typically, this was destructive in world wars. This was what they were always worried about. We talked a little bit about the sulfanilamide powder that we had and that were in the wound packs of World War II, and they would sprinkle it on the wounds because they would have bone and dirt. I mean, war wounds are horrible in the days before chopper evac, and that really saved a lot of limbs in the Allied forces because the Axis forces, the Nazis and the Japanese and the Italians did not have that. And having seen many cases like this is typically a devitalized foot. This is somebody with bad circulation. This is somebody who has had a bad injury and it didn't get cared for right away. Somebody had a lot of underlying disease. It swells, it smells, it's horrible. Clostridium perfringens is the most common. There's other Clostridia, same type, gram-positive, anaerobic rod, endospore former. Again, gas because it got gassy bubbles that you can see. And if you take an x-ray gas under the skin, you wouldn't confuse it with toxic shock. Once you don't see the necrosis, this is the gangrenous foot. Black, modeled with black, and they're perfectly aware of what's going on, and that something is happening because it doesn't affect mentally until you get to the point where it's become almost systemic, near death. Okay, it's an extraordinarily unpleasant thing. Okay, long delays is really, and that's with chopper evac and things like that. Totally different world today. All the things that can happen to it, again, cytokines release, and that will lead to really the late stage complications. And this is one of the things when you see sometimes vaginally in healthy women, we were seeing in the days of the people doing abortions because they were, not easily accessible, illegal in a lot of areas. And this was, again, probably one of the things that triggered people. They would get gangrenous uterus, people would die from these botched abortions that were there. Surgical wounds, self-induced, or somebody had no idea what they were doing, which is often the case. A lot of oxygenation of tissue. Understand, and I'm going to get to that point, antibiotics, hyperbaric oxygen, etc., etc. This is not what diabetics get. Can it happen in diabetics? Yes. Diabetics get something called dry gangrene. Bad circulation, all of a sudden a blood vessel blocks a tiny arterial and a toe turns black, a finger turns black. If it's a larger clot, maybe part of the foot turns black, part of the upper extremity turns black, starts to devitalize, and eventually turns black. It's very noticeable. Sometimes it's relatively sudden in its onset. That's called dry gangrene. There's no infection involved. Your whole effort to treat it, the tissue is going to die. It's just like the necrotic stump of the umbilical cord. It's going, you hope it does what we call demarcate and fall off. In other words, as long as you keep everything clean, wherever there's been no blood supply, you'll let it come off and hopefully you'll be healthy underneath it. Same thing is true with diabetic toes. You're going to see these in the hospital, many of you. You're going to have patients, you're going to keep the covers off. You're going to gently cleanse them with something very mild, dilute peroxide, even just soap and water. And be very careful not to get anything on top of them or to irritate them, because then they develop what's called wet gangrene. That's a dry gangrene that is now infected secondarily. That's a mess, and it's usually going to result in an amputation. Typically, what happens, I mean, you'll see this in patients. Patients will describe this at home because you warn them. All of a sudden, a little piece of toe will fall off. It's real. I mean, it's just weird. But we've seen, and I've seen it. I've taken off patients' socks and had pieces of toe in them, just to give you an idea. It's something you got to get used to. So dry gangrene does not have an underlying microorganism. Secondarily, it becomes wet gangrene. Gas gangrene is a clostridial infection, and that's typically from a massive wound, a la war wound, open fracture, terrible traffic accident, that type of stuff. And then we're getting very near the end, thankfully. These are bite wounds. Animal bites, there's differences between them. Okay. Dog bites are bad because they grab and they pull into your dog, pulling side to side. I'm talking about him, he's looking at me. So they crush, they puncture, and look, frankly, and like anything, there's a lot of bad stuff in the mouth, and there's a lot of these. What the rule is this: you do not under animal bites. They're going to get infected unless there is an overly. I'm trying to think of the right word. At least there's a really significant chance of or a real chance of cosmetic damage. Do you take that chance of putting in sutures? Okay, you generally want to let them heal without that. My granddaughter, the one you've seen pictures of, who's now 23, when she was like 3 or 4 years old, her other side's grandfather had a dog. The dog one Christmas, bit her. There's no other way to say it, in the face. They took her to the hospital. There was a 24-hour wait. This was over in New Kensington. And took her to the hospital, the old Citizens Hospital, not there anymore. There was a 12 to 24-hour wait for stitches and for treatment over at Children's, because my daughter wanted to race her over to Children's. The reality was that they had a very good ER doc who was able, and he said that, I'm going to put her on antibiotics, we're going to clean it. It looks relatively clean for a dog bite, because fortunately, it was in a skin crease. He was able to suture it. There's absolutely no visible evidence of it. As you can see, it healed divinely for anything that you would even have to put stitches in. He must have, maybe he was a plastics resident, moonlighting in the ER. Who knows? It worked. That's the exception to the rule. Most of the time, if you're going to put stitches in, you stitch it fairly wide, not as, you don't close it very neatly. You want to leave spaces because it's going to drain. It's going to get infected. You put them on antibiotics. Typically, for animal bites, the antibiotic choice, if they're not penicillin allergic, is augmentin, as you will see shortly. They very often, animal bites have Staphylococcus aureus, where you want to use a penicillin-based, and typically it's not MRSA. Okay, at worst, it's one of these beta-lactamase producers. And there's another thing called Pasteurella multicida or multicoda. That's a gram negative. That's why you want to use the augmentin, and that's why you want to use the amoxicillin. Remember, there's amoxicillin and that clavulanic acid. That is the drug of choice, and that's what they put her on, incidentally. So there are lots of different things that can be in there. Yes, the potential is for all sorts of bad stuff. Human bites are worse. You just don't want to suture them at all. And if it's a terrible bite and you know you're going to require plastic surgery, what you might have to do is we call it retention sutures. You close the gap with a stitch, big stitch here and a big stitch there that you're willing to take out, understanding that 6 months, a year from now, we're going to have some major plastic work to be able to do. The human mouth is worse than the animal mouth. It always has got anaerobes in it, Bacteroides particularly. You probably would have to use 2 antibiotics, I would think, on that. At the very least, you'd have to use metronidazole. Maybe you'd have to use that with something else. Metronidazole, Flagyl to cover the anaerobes, and depending if you're allergic to penicillin or not, some other agent, another broad spectrum agent. It's just awful. Most common causes of this are 2, typically fights. It's not, people don't routinely bite each other. We're not talking about somebody being playful, and we're not talking about something might happen with a baby accidentally biting. The mouth is not that well cultivated at that point with these organisms. The 2 things are what causes fights: alcohol, number 1, and the other thing, speed, methamphetamines. Amphetamine use, those kinds of stimulants, very, very common when people are the nature of them is very combative, very angry, very short-tempered. Because when alcohol is a disinhibitor, those are the 2 big players that are involved with it. Okay, crushed tissue, all sorts of bad stuff that are there. Drunkenness, forcible restraint, poor mouth hygiene, like that. And again, so all of these, you have to open them up, drain them, etc., etc., all this good stuff is there. Here's the multicida, the way it is around. Lots of animals, dogs and cats. Cats puncture more. Okay, they're more of a puncture wound. So that's another one that you have to be, again, both of these we'd be looking at tetanus prophylaxis. That's always going to be a consideration. You think more about punctures. I really think cat bites are worse. Myself, I think they're more likely to get infected even than dog bites, but I think they're worse having had one. Okay. You're trying. I was trying to get one of our cats when before we get married. So we could take so the cat could go and be kenneled during my honeymoon with our first wife. Yeah, took a chunk out of my finger, just nailed me. Good Lord, love a duck. And so it's not really clear. But this is thankfully it's gram negative and it's relatively easy to treat with antibiotics that are there. Beta lactamase, that's where the augmentin comes from. Clean them right away. Cat scratch type of things. Like I said, they're in the litter box. All those things. Bartonella Hensley. I'm not going to ask a question about that, etc., etc. Rat bite, same thing. I'm not going to ask a question about that. But you can see there's problems all over. All of these require tetanus prophylaxis, by the way. And sporotrichosis, the little thorns on roses. This is a fungal. I have seen that. It can generally be treated. Typically, you have to use some type of antifungal agent systemically, and probably open them up. But those will get better. I think that's everything. We're good. Presentation completed. Happily so. Bye, everybody. Thanks.